Welcome to this edition of AFMC
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of. Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to this episode of AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Whit Hall. He is a neonatologist and a professor of neonatology. Dr. Hall, thank you so much for being here.
Well, thank you for the opportunity. I really do appreciate the opportunity to talk about one of the things that we've been working on for a very long time.
Well, tell me about the increase in infant mortality and what you're seeing.
Sure. That's a great question. I've also had a chance to look at the report. This is the recent CDC report that talks about the vital statistics, not only here but in Arkansas, but nationwide. And yes, there is an increase in infant mortality that has been from one year to the next. It's a relatively minor increase. It's only 3%, but given that many the numbers of babies that we're talking about that have died, and that's a very large number of babies that have died this year compared to last year. And it's what we call statistically significant, which means that, it's unlikely that it's due just to chance.
And what are you seeing as some of the reasons for that change?
There are two reasons that I saw that I thought were significant when I looked through this report. The first thing that I saw, and there's been a marked increase in two things. Number one, there's been a marked increase in bacterial sepsis of the newborn, okay? Why is that? Well, one of the things that we have done in perinatal medicine, we give prophylactic antibiotics to mothers that have a positive culture for group B beta hemolytic strep. And that's been very successful, and that's decreased the incidence of that. However, there are other organisms now that are taking the place of group B strep, specifically gram-negative organisms such as E. coli. And that is, we do not prophylax for that. And so that is probably one reason. I think the other reason is that we are now working to save babies that are 22 and 23 weeks gestational age. And this is something that is not very well appreciated, but these babies have very thin skin. A term infant will have about 15 to 17 layers of what we call epidermal tissue, whereas a very premature infant will have maybe one cell layer thick. Because of that very skin thin, these very tiny babies are very much at risk to die of bacterial sepsis. And as we've started taking care of these babies that are delivered at 22 weeks gestation, which is at about 12 ounces, not 1 pound 12 ounces, but 12 ounces. Many of these babies, in fact, most of the deaths are due to bacterial sepsis. So I think that's one reason. The other reason is maternal complications of pregnancy. Bacterial sepsis has an increase of 14 per 1,000 deliveries. Maternal complication of 14%. Maternal complications of pregnancy is 9%. There are probably two big reasons for that. Number one is maternal obesity. That's a huge risk factor. And we're seeing mothers now that are way overweight. And so that's one of the things that we can really work on to help prevent that. The other thing is preeclampsia. Preeclampsia is a tougher nut to crack. We just don't understand all we know about preeclampsia. What we do know, it seems to be an autoimmune reaction. One of my daughters had preeclampsia and had to deliver early because of that. And it is a disease that can cause babies to deliver early. Additionally, these babies can be growth restricted. So those are probably the two main drivers for the increase in infant mortality, at least nationwide.
And speaking of nationwide, is that what you're seeing in Arkansas too, the same patterns here?
We are certainly seeing the same pattern. And now that's all anecdotal evidence. The recent report did not it is not that granular so that we can go in and take a look at what happened and what is happening in Arkansas. But what we know, what I can tell you at least anecdotally, and that's not very good evidence, to be honest with you, but we've certainly seen that. And the babies that we take care of, and we take care of probably at least half of the babies, probably a little more, of these babies that are born at 22, 23, and 24 weeks gestation. Most of the babies that die, they die of bacterial sepsis. So we're certainly seeing that in Arkansas, and we're definitely seeing an increase in maternal obesity and in preeclampsia in our state.
Let's switch gears just a little bit. How has telemedicine made a difference in this type of work that you do? Has it become more prevalent?
That's a great question, and thank you so much for asking. Yes, we've actually published on that. Telemedicine was instrumental in initiating our perinatal regionalization in our state. It was interesting that we found back in 2008, 2009, working with Goldman and Dick Nugent, we found that the incidence of death in babies that delivered in smaller nurseries and babies that were under 1,000 grams was as high as 30%. In medium-sized nurseries, it was 20%. In large nurseries, the incidence was 10%. So by initiating perinatal regionalization, where we initiated maternal transfer to where the mothers were transferred to where the babies were going to be cared for, made a huge difference in the number of babies that died that were in these lower gestational age groups. And in fact, we lowered our infant mortality from about 8.5 per 1,000 down to 7 per 1,000. In the meantime, it has jumped back up, but that may be due to some other factors that we can talk about later, but a lot of that is what we call post-neonatal mortality.
And infant mortality is divided into two different, is it time frames? What does that mean?
Yeah, that's a great question. The two time frames are what we call neonatal mortality, which is death between 0 and 28 days, and post-neonatal mortality, which is death between 29 and 365 days. So those two time frames divide the babies up into when they don't survive and when they die. Most of the complications of prematurity occur in the first 28 days of life. But after the 28 days, many of those deaths, in fact, the most common cause of death is sudden unexpected infant death. And so that is something that we can get a handle on and we can decrease. Arkansas tends to be about in alignment with the national average for neonatal mortality, which is around 4 per 1,000 live births, okay? 2 per 1,000 live births are due to diseases of prematurity, such as extreme premature birth, 22, 23, 24 weeks. And then the other big component of that is congenital anomalies, such as trisomy 13 or 18. And those babies often tend to die in the neonatal period, either because of palliative care or because they have severe congenital defects that are not compatible with survival. So that accounts for about 4 per 1,000 live births. Nationwide, post-neonatal mortality is around 2 per 1,000 live births. In Arkansas, it's between 3 and 4 per 1,000 live births. That's way too high. There's one big thing that we can do, and that is to help put babies back to sleep. Okay, and that's why back to sleep is so important for helping to prevent sudden unexpected infant death, which is the most common cause of post-neonatal mortality and something that we can actually prevent or help prevent. We cannot prevent it entirely.
And do health inequities play a role in this as well?
Absolutely, there's no question. Racial and social inequities, there are two things that are important to understand. Number one, in the African American population, the incidence of preterm delivery is much higher. In fact, it's twice as high in babies that deliver under 37 weeks. The incidence of preterm delivery is twice as high. So the incidence of preterm delivery is around 10 out of 100 babies, 10 to 11 in the African American population. and sometimes even higher, particularly in lower socioeconomic groups. It can be as high as 12 to 13 per 100 deliveries, whereas in the white and Hispanic population, it's around 5.5 to 6.5 or 7 per 100 deliveries. And so the incidence of preterm deliveries, it's much higher in the African American population, and that is further influenced by lower socioeconomic groups.
How can we prevent this?
That is a wonderful question, and if we had the answer to that, I think we could retire right now. But we don't know, is the short answer to it. There have been many studies that have looked at stress, particularly racial stress, in the African American population. That certainly seems to be a risk factor for preterm delivery, and that stress is heightened in African Americans. And particularly when you compound that, when it's compounded with socioeconomic inequities, then that causes some really significant changes in our incidence of preterm delivery. So that's one thing that we can do to help decrease the economic gap would be huge. How we do that, Robin, as you know, that's very difficult. But one thing that we do know is that education can be a big part of that, and that's something that we can really work on. The other thing that we can work on, at least in Arkansas leads the nation in teen delivery. So really putting an emphasis on birth control and methods of safe sex at the very early age group, and that includes as early as junior high. Because these kids are much more adept at understanding and going through all of the things that they can get online, and that's where they get all of their information. I think that getting good information, which includes good methods of birth control, is extremely important. And that oftentimes needs to be done in the schools, because sadly, oftentimes these kids do not get that information at home.
Does that even start with the pediatrician? A lot of that education within wellness visits or seeing their pediatrician too? Absolutely,
it does with the pediatrician. The pediatrician can be very helpful with that. Having said that, I don't think it's up to the pediatrician to have what we would call the talk with our teenage daughters or our teenage sons. I think that's up to the parents. But I think the pediatricians have a big role to play to at least talk to the teens and talk to the families about the importance of safe sex, about the importance of pregnancy, because as we all know, pregnancy in high school or pregnancy in the teenage years has significant socioeconomic effects, not only for the baby, but for the mother as well. And so they're much less likely to go on and continue with their education if a mother has a baby in high school, and they're much less likely to be part of the American dream.
Let's switch gears just a second. Tell me about COVID vaccinations, and should pregnant women, expectant mothers get those vaccinations? Have you seen that affect the rate within the state too?
Absolutely. We have a very high rate in our state, particularly in certain areas of our state that are associated with less vaccination. This is why the COVID vaccine, the flu vaccine are important. COVID actually does not affect the neonate except in very rare circumstance. It can do it, what we call vertical transmission, which means if the mother has COVID, her transmitting the virus to the fetus through the placenta is actually very rare. That happens very infrequently. However, if a mother is pregnant and she gets COVID, then she is much more likely to have respiratory distress and have to deliver early. I think stories are oftentimes helpful, and this is anecdotal, but I will never forget a time when I was consulting a mother and she was pregnant and she had COVID, and she was having significant respiratory distress. When I was talking to her about the fact that she might have to deliver at 27 weeks gestation, I thought, I'm not going to make it out of this room before she has to go on the ventilator. She was on a very high flow oxygen. The next day, she had to go on the ventilator. And when that happens, we have to deliver the baby because the baby compromises the respiratory system because it compresses all the diaphragm. So she subsequently went on the ventilator, and the baby subsequently delivered. The mother was so sick, she had to go on heart-lung bypass or ECMO. She actually survived that, but she was on heart-lung bypass for a week. In the meantime, the baby, who was born at 27 weeks, normally that's a walk in the park, but about 5%, 3 to 5% of our babies get a condition called necrotizing enterocolitis, which is a bowel inflammatory disease that prematures get. And the baby develops short gut syndrome, which means that the baby had to be on hyperalimentation for months after delivery and has adverse neurodevelopmental outcome, primarily because the mother did not get vaccinated for COVID. A simple shot would have prevented that. I recognize that many people are concerned about these vaccines, but there is probably nothing in medicine that has a better risk-benefit ratio than the vaccination. There's risk to everything we do in medicine, including taking out an appendix. But vaccines have the lowest risk and the greatest benefit of anything we do in medicine. So please, if we don't do anything else, encourage our mothers to get vaccinated.
And does RSV, the new vaccination for it, does that come into play as well?
Yes, RSV is an excellent vaccine, and the reason that it's good for the mothers to get vaccinated for RSV is because the antibodies get transmitted to the fetus, and that can help the fetus. In addition to babies, and that depends on availability. Right now, we don't have adequate availability with all the RSV vaccines, but hopefully that will come shortly. Generally speaking, the RSV uptick starts in November, December, and it really tends to get to peak in January and February. So hopefully by the time the peak RSV season gets here, we'll have availability to be able to vaccinate everybody against that disease.
And before we go, syphilis is on the rise and across the country, not just here in Arkansas. Are you seeing that affect babies?
Yes, it's particularly in certain areas of our state, particularly northwest Arkansas, for whatever reason, in western Arkansas, there seems to be a large uptick of syphilis. Syphilis is a disease that can affect every single organ of the baby. For example, it can affect the blood clots. It can cause decreased blood counts. It can cause decreased platelet counts, which is a clotting part. It can cause liver dysfunction. It can cause bone disease. And probably the most significant thing that it does, it can affect the baby's brain, because babies can get meningitis as a result of syphilis. Now, we have treatment for syphilis in the newborn, and basically all mothers virtually that deliver in a hospital are screened for syphilis, and we can treat it. But if a baby has intrauterine meningitis, then the treatment, even though the babies get treated, they often have long-term neurodevelopmental issues. In addition, one of the things that can happen with syphilis is that as we kill the organism, if a baby is overwhelmed with the organism, the baby releases toxins and can cause what we call a Herxheimer reaction. I've actually had a baby die from that with very high fevers, 104, 105 in the neonate, and that can cause death. And so just because we can treat it doesn't mean that we don't need to actively prevent it and also actively screen for it.
Well, Dr. Hall, thank you so much for talking to us about a number of things affecting infant mortality. I appreciate the work that you're doing. Thank you.
Thank you for the opportunity.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.